very complex guideline, this one, and I think the reason why it's even more complex is because there are very few randomized controlled trials. Therefore, the vast majority of recommendations is actually class 2. In your daily practice, what is important is the class 1 recommendations. And the class 1 recommendations are the things that you should do. So for that reason, I have only focused on the class 1 recommendations that are in there. So therefore, I think we take much more time to go through that, because this is the one thing that you really want to remember. I would just, before I start, like to see the hands raised. Who of you is involved in transcatheter aortic valve replacement? So very few. Okay. So this shows the fundament of every guideline. I always like to show that because it reminds us what we do. Class 1 recommendation is evidence and or general agreement that a given treatment or procedure is beneficial, useful, and effective. And the way we say it in the daily practice is what one should do, must do. Then you see class 2 in the middle, conflicting evidence. We don't know exactly where we are, or a divergence of opinion about the usefulness or efficacy of the given treatment or procedure. So some say yes, others say no. Class 2A, we feel that it is more positive than negative. And class 2B, we feel that it's not clear. So 2A is a little bit stronger than 2B. And the way we put this is that a class 2A should be considered, you should think of it, whereas a class 2B you may consider. So it's weaker in evidence. And the class 3 is important also, because the class 3 says evidence or general agreement that a given treatment or procedure is not useful or effective, and in some cases may be harmful. And what we say is should not do, is a no-go. For you to remember in this guideline, and every guideline we do, is a class 1, there is enough evidence to do, and a class 3, we should not do. The evidence that is then evaluated by a task force who writes this guideline, the evidence you can split in 3 levels. Level A, level B, level C. The only important one is level A. That means you have data derived from multiple randomized studies or meta-analysis. That is the highest recommendation we can give. So if you give a class 1, recommendation A is really you should do. Most of the evidence that we have is the level C. That is consensus of opinion of experts, or small studies, retrospective studies, but also registries. So level A is the highest you can have, but level C is more what we do in the practice. You could even think that level C is probably more important, because that's what we do in the practice. I give you an example. One time they published in the British Medical Journal that if you have in a plane, the plane is going to crash, and you're going to randomize your patients, your individuals in the plane, to yes parachute, no parachute, you know the outcome, but there will not be any randomized trial on that. So this is basically where we are. A lot of this information, there are no randomized trials, because simply we do as we do. What is important if you look at the valve guideline, that there are important questions in the evaluation of patients for valvular intervention. That means either surgery or transcatheter. The questions that you ask yourself are, how severe is the valve disease? What is the reason of the valve disease? Does the patient have symptoms? Are these symptoms related to the valve problem? Are any signs present in asymptomatic patients that indicate worse outcome if you delay the intervention? What are the patient's life expectancy and expected quality of life? These are the main questions that you ask yourself when you think about these patients. Do the expected benefits of the intervention outweigh the risks? In other words, is surgery or transcatheter approach better than doing nothing? Because a surgery always has a risk, and doing nothing also has a risk. What is the optimal treatment modality? Should I do surgery? If I do surgery, should I repair or replace? Or should I do a transcatheter intervention? Are the local resources, your experience, your equipment, are they good enough for the intervention that you want to do? And last, very important, what does the patient want? In Europe, we see more and more that patients come and say, I want a transcatheter and I do not want surgery. And that is something we have to live with. In the guidelines, we are working towards patient engagement. That means that the patient is represented in a guideline committee and listening to the patient what they would like. Patient engagement. This is because I'm going to speak only about aortic stenosis, mitral regurgitation, and tricuspid regurgitation. This is the management of severe aortic stenosis. Here you see that. Management of severe aortic stenosis. The first question that you have, are there symptoms? If there are symptoms, yes. Is there absence of comorbidity or general condition that make benefit unlikely? If no, we're not going to do anything. If the patient is too sick to operate, we're not going to do surgery. First question, will the patient survive surgery? If not, full stop. If yes, then we go low risk and other characteristics that favor transcatheter valve. Yes. Then we go to a surgical procedure. If, however, the risk is high, we think about the transcatheter approach. So the basic message for you is, if the patient is very sick, you think more about transcatheter than about surgery, because the patient will not survive surgery. Okay? So this here is the right part where we make a decision between surgery or transcatheter. If the patient has no symptoms but has a low ejection fraction, then he goes for surgery. If the patient has no symptoms and he has a low ejection fraction and he is physically active, and if he's not, then you think about doing nothing. The patient is too sick to be treated. If the patient is still active, then you go to exercise testing. You look if during the exercise test the blood pressure falls. That means that he has a severe aortic stenosis. If that is a yes, then you go for surgery. That's what you see here. If it's no, you look for the presence of risk factors and low individual surgical risk. Yes, he can have surgery. No, you do nothing. Basically what it comes down to is if the patient is very sick, too sick for anything, you do nothing. If the patient is excellent condition, has a severe aortic stenosis, you go for surgery. If the patient has severe aortic stenosis and is not too sick, but also not excellent condition, you think about transcatheter valve. That is all you need to remember. Indications for intervention in aortic stenosis and recommendation for the choice of what you do, surgery or transcatheter. We're only going to focus on the red arrows because I told you we only look at the class 1 recommendations. We're talking here about symptomatic aortic stenosis. The patient has symptoms. Intervention is indicated in symptomatic patients with severe high gradient aortic stenosis. Class 1, level B. Intervention is indicated in symptomatic patients with severe low flow, low gradient aortic stenosis with low ejection fraction and evidence of flow, contractile reserve, excluding pseudo-severe aortic stenosis. That's a difficult one. A low flow, low gradient means that your heart is not pumping anymore, but the valve is closed. So that means that you cannot reliably measure the aortic stenosis. In these patients, we say class 1C. We do not have much evidence, but we feel that we should do it. Okay? The choice for intervention must be based on careful individual evaluation of technical suitability. Is it technically possible? And weighing the risks and benefits each time. In addition, how good is your surgeon? How good is your cath lab? And outcomes data for the given intervention must be taken into account. In other words, how much evidence do we have? Surgery is recommended in patients with low surgical risk and no other risk factors not included in the score, such as frailty, porcelain aorta, or chest radiation. That's a 1B. We think about transcatheter if we cannot do surgery. And you discuss each of those difficult patients in a heart team. A heart team is a group of people, a surgeon, an interventionalist, a heart failure person, clinical cardiologist, imaging specialist, nurses, anesthesiologist, etc. All together, they take the decision, do I do a transcatheter valve or do I do a surgical valve? Okay? Now we go for the asymptomatic patients, the ones with severe stenosis but no symptoms. Surgery is indicated in asymptomatic patients if they start to have LV dysfunction. Means that the ejection fraction is coming down. That is a class 1, level C. We think we should do, but we don't have studies. Surgery is indicated in asymptomatic patients with severe aortic stenosis and an abnormal exercise test. That's also 1C. When do we do then a transcatheter? A transcatheter is what you see here in this table. We do when the patient has a high risk score, when there is lots of comorbidity, when he is older, when he had cardiac surgery before. So all these very sick patients, we cannot operate. So we think about the transcatheter if there is severe aortic stenosis. There's a whole list of these considerations. If the patient is very frail, frail means that he's very old, cannot walk much very more, only sits in the chair, then we better do a transcatheter and not a surgical. If he cannot move, if he has a favorable access for a transfemoral, that means through the femoral artery, then we consider a transcatheter approach. If he has previous cancer and he has radiation on the chest, then we prefer to do a transcatheter because cutting will not be easy for surgery. If the patient has a porcelain aorta, that means that the aorta is fully calcified. We prefer to do a transcatheter. If there is presence of intact coronary bypass graft when sternotomy is performed, we like to do a transcatheter. If there is the expectation of a patient prosthesis mismatch, we like to do a transcatheter. And if the patient has severe scoliosis, that means that his spine is like this, we like to do a transcatheter. All these other things here, we like to do surgery. Mostly if we cannot do a transcatheter for other reasons. You don't need to remember all these reasons, but what you do is you discuss in the heart team with the surgeon, the cardiologist, the interventionalist, and you discuss all these things, and together you take the decisions. So it's much more complex than it used to be in the past. In the past, say operation, yes or no, and that was it. Here again, all these indicate better surgery. If you have mitral regurgitation, if you have also tricuspid regurgitation, if you have an aneurysm of the aorta, if you have septal hypertrophy, all these things need other surgery. So then don't do a transcatheter, but do a surgical procedure. I've tried to give you in a nutshell. First you decide, is there severe aortic stenosis? If there is it symptomatic or asymptomatic? And then your last question is, do you do a transcatheter or do you do a surgical? These are the 5 rules of aortic stenosis. Now we're going to go to mitral regurgitation. The first part is the management of severe chronic primary mitral regurgitation. Each time we start with symptoms. If you have symptoms, the second question is, how is your ejection fraction? If it is good, we go for surgery. If the ejection fraction is not good, we think about, should we do medical therapy? If the patient is not listening, not responding to medical therapy, then we think about, is there a durable valve repair? If yes, then we go for surgery. If the patient responds well to medical therapy, we just do medical therapy. And each time you follow these algorithms. But basically it comes down to, is it an easy surgical patient or not? If it's easy, you operate. If it's not easy, we probably wait. Now we go to the more difficult one. The patient has no symptoms, but severe mitral regurgitation. We want to know, is this heart large and is his ejection fraction low? That means that he is already going down in cardiac function. In that case, surgery. If there is no dilatation, then you think about, does he have atrial fibrillation or does he develop pulmonary hypertension? If he has that, don't wait. You need to go for surgery. If he doesn't have any of that, you just follow up and you wait. So basically the bottom line here is, if the patient is sick, has symptoms, probably operate. If the patient is not sick, has no symptoms, you wait. But you see on your echo, if the heart is getting bigger, if the function is going down, then probably you need to think about surgery. That is more or less in a nutshell what you should do. These are the indications that we have. A surgical mitral valve repair should be the preferred technique when the results are expected to be durable. That sounds complex, but what it states is, if you think that you will have a good result, you should do it. Surgery is indicated in the symptomatic patient with a good ejection fraction. Surgery is indicated in the asymptomatic patient when the function is going down or the heart is dilating. That's all you need to remember for the mitral regurgitation. Now we switch to secondary mitral regurgitation. The secondary mitral regurgitation is a regurgitation that is, the valve is okay, but the heart is getting bigger, therefore the valve starts to leak. It's not a valve disease, but it's a heart disease. That happens if you have a big infarction, heart dilates, the valve is no longer closing. Surgery is indicated in patients with severe secondary mitral regurgitation if I send them for bypass surgery anyway. So I'm going to do the bypass. I know there is a valve problem. Then we do the surgery. Only then. All the rest is not class 1. Now we go to the last one, which is tricuspid regurgitation. We start to see that if a patient has severe tricuspid regurgitation, that 50%, maybe 40% of them only live beyond 3, 4, 5 years. In other words, if you have severe tricuspid regurgitation and you do nothing, the patient will be dead in 3 to 4 years. So we need to think if we should do something. Is there a need for left-sided valve surgery? That means, does he have an aortic stenosis or mitral regurgitation surgery anyway? If yes, then think about severe tricuspid regurgitation. Is it severe? Try to operate that as well. If it is not severe, then you wait. If there is no need for left-sided surgery, you're not going to do a mitral valve repair, you're not going to do an aortic stenosis, but you do have severe tricuspid regurgitation. This is more or less the isolated tricuspid regurgitation, which can be pulmonary hypertension, which can be a pacemaker lead, all of that. If it's severe secondary TR and there is no abnormal function, then you wait. If it's severe primary TR and the patient has symptoms, you do surgery. That's basically the bottom line. You look at the indications and you look at the symptoms, and based on that you decide for surgery. Tricuspid stenosis is something we don't see often. Surgery is indicated in symptomatic patients with severe tricuspid stenosis. Surgery is indicated in patients with severe tricuspid stenosis if they're already having some surgery on the left side, mitral or aortic. This is more important for us. Primary tricuspid regurgitation. Surgery is indicated in patients with severe tricuspid regurgitation when they are doing left-sided surgery anyway. And surgery is also indicated in symptomatic patients with severe isolated primary tricuspid without severe right ventricular dysfunction. In other words, if my left ventricle is okay, I'm not going to do any surgery. But my right ventricle, the function is still good, but he has a lot of regurgitation, then it's better to do surgery rather than wait until the ventricle is finished. The only one in secondary tricuspid regurgitation. Surgery is indicated in patients with severe secondary tricuspid regurgitation undergoing left-sided valve surgery. In other words, if you're going to operate on the left, on the aortic or on the mitral, you look at the right side. If there is severe tricuspid regurg, you go for surgery. This is the last slide. It was a complex business, this, and I tried to make it very simple for you. We spoke about mitral regurgitation. We look at primary. That means that it is a valve problem. It's a prolapse, usually. And we look if the patient is symptomatic and how is the heart function. If it is secondary mitral regurgitation, it's because the ventricle is a problem, and therefore the valve starts to leak. If you do a bypass, you also operate the valve. We spoke about aortic stenosis. Severe aortic stenosis we split in symptomatic and asymptomatic. Symptomatic, almost always operation or transcatheter. Transcatheter if the patient is too sick. If it's asymptomatic, we look if the ventricle is already suffering. If the function is going down, then we think about surgery. We spoke about the tricuspid, where the most important one is the secondary tricuspid regurgitation. I have a mitral valve problem Then I look at the right side, I see severe tricuspid regurgitation. I'm going to repair the mitral valve. So I'm also going to repair the tricuspid valve. The only thing is if you have isolated tricuspid regurgitation, only tricuspid, then you repair it if the patient is not yet getting RV dysfunction, but is going in the direction. What is important that ESC highlights the need for the heart valve team. These are no longer decisions that I can take together with a surgeon. These are decisions you need to take in a team where you have a surgeon, a cardiologist, an interventionalist, a heart failure specialist, an anesthesiologist. All of those people should be there because it's very complex. This is truly academic medicine. So the ESC highlights the need for the heart valve team where the patient is central. And that is basically what I wanted to share with you. I realize that it's very